So Mycobacterium tuberculosis, they isolate, which is resistant to rifampicin and isoniazid, are MDR-TB strains. That is multiple drug resistance TB. Whenever you basically are a sensitive TB, a case of sensitive TB, you need to take your medications without interruptions. That is very important. That is uninterrupted treatment of sensitive TB, first line drugs, will prevent you to get converted into MDR-TB. First thing. That means suppose if in case you stop your medications in between, if you interrupt your medications in between the first line drugs, there are higher chances of you developing MDR-TB. Second would be inappropriate dosages. For example, as per the weight. For example, if my requirement as per 45 kgs weight is 450 milligram rifampicin, but I am not being prescribed an appropriate dose as per my weight, if the dose given to me is less than the weight-based therapy, then definitely chances of again getting a resistance would be very high. Third, giving a divided dosages. For example, 450 milligram requirement of rifampicin. Suppose if you give me 150 in the morning and rest 300 in the afternoon or the evening period, would definitely again be a risk factor for developing DR-TB. Suppose my requirement of pyrazinamide is 1500 milligram. If doctor prescribes me 70 milligram in the morning, 70 milligram in the evening, that is the divided dosages of the drug, definitely again high risk of developing DR-TB. Fourth, any immunocompromised state. For example, if the patient is having uncontrolled diabetes, patient is having renal failure, patient on dialysis, renal failure, uncontrolled diabetes, or say patient is having any immunosuppressive status, that means the immune system is on the lower side, the chances of developing tuberculosis per se is very high. And that too, if there is any DR-TB contact at home, a primary case of DR-TB at home, and comorbidities, definitely the chances of developing DR-TB again goes high. Fourth, similar way, even alcoholics or drug abuse having a DR-TB contacts again may lead to high DR-TB, chances of risk factors of high DR-TB. So these are some of the risk factors where patient may develop DR-TB. So whenever the patient is having, and most importantly, if the patient has been prescribed medication or first line drugs without knowing the sensitivity or microbiological diagnosis or the DST pattern of the patient and giving him the medication just on basis of radiological, again chances of DR-TB is very high. You need to have information of all first line drugs, whichever you're giving, especially rifampicin and isoniazid. If the patient has been taking this first line drugs, we need to have information of sensitivity of these two drugs. It's very important for us. Many times we get prescriptions on field as clinico-radiologically diagnosed as DR-TB. That is very wrong. We cannot diagnose DR-TB radiologically. Let me be very clear over here. You need to have a good microbiological diagnosis only. So DR-TB can be diagnosed first by gene expert. Gene expert will tell you information only about rifampicin drug, one single drug rifampicin, but rifampicin is precursor for DR-TB because 95% of the time, if the patient is resistant to rifampicin, will also be resistant to isoniazid, 95% of the time. So considering gene expert as a precursor for DR-TB, gene expert is a very good tool with a very good sensitivity. So for example, if not necessarily you always need to have a CBNAT, many times right now we are considering even TrueNAT. We are having these two modalities, two modes of tools right now. That is, one is CBNAT and second is TrueNAT. Both of them showing you gene expert as RIP resistance or RIP sensitive. So first and the foremost, very helpful tool. Second, line probe assay. And again, line probe assay is a molecular test which gives information about first line drugs rifampicin and isoniazid. Also a second line drug ethinomide on first line LPA. Similarly, even second line drugs, it will give you further added on information about the FQ and the second line injectable amino glycoside sensitivity. But for diagnosing DR-TB, that is MDR-TB, first line LPA is more than sufficient. So second tool over here is first line LPA, line probe assay. Third is the gold standard technique, that is microbacterial growth indicator tube, that is also called as liquid cultures. Liquid culture. Once the culture is positive, then we further do the DST or first line drugs. And depending upon the resistance and sensitivity, we may label the patient as MDR-TB or even pre-XDR, depending upon the resistance or sensitivity of quinolones also. So these are some of the tests which will give you an information about the DRTB, diagnosing DRTB. There are some furthermore new tests right now in market, for example, pyrosequencing, or maybe NGS, that is next generation sequencing. So even these are for more tests which will give you an information about the first line drugs and second line drugs as well. So basically DRTB is a microbiological diagnosis only. You cannot diagnose on radiological basis. So it depends upon the immune system over here and your counseling. If your counseling is really good and if the immune system of the family members is really good, chance of developing DRTB is less. But if you haven't counseled the primary patient, or if the immune system is really not good of the patient or of the relatives, and if there is some high comorbidities over there, for example, say diabetic patient, uncontrolled diabetic patient, or maybe a renal failure case on dialysis, or some patient who is on steroid for the long duration of time, the chances of DRTB developing goes very high. One single DRTB patient may make at least 12 patients per year, okay, but not necessarily always in family or close contacts. So you just need to counsel a patient thoroughly, that you need, especially cough etiquettes is very important, especially, they are not supposed to share their same spoon at the time when he is having it over there. So basically you just need to explain them how DRTB or rather how any TB spreads to each other. That's very important. So if you counsel your patient as a relative properly, it is not necessary that that all each and every member will develop DRTB. It is not necessary. Counseling should be really very good. Yes, why not? MDR-TB is treatable, to be very frank. So if you go as per the literature and the national figures, MDR-TB initially those days, there were days where the DRTB cure rate was only 45%, which has increased to good 60-65%. But now we also have national figures where cure rate of DRTB has come up to 75 to 78%. It's really good. So right now we have new drugs in market, which take care of even pre-XDR and XDR-TB. So cure rate has gone up, undoubtedly. We have a good cure rate of even 91% in BPAL trial. Genix trial has already proven of pre-XDR-TB getting cure rate of 91% as per the Genix trial. So even pre-XDR-TB can have a cure rate of 91%, which is really good with the new drugs like pretomanid, bedaquiline, linezolid. So there are new drugs in the market. There are new regimens in the market, because of which the cure rate has gone really high. I would just like to give one single message. First is, please follow all the instructions given by the doctor. Second, it is very important to catch hold or to follow one single doctor rather than keep changing the doctors. It is not at all a good decision of doing doctors window shopping. More and more you change doctors, more and more your case will get complicated. But selection of doctors is also very important. Not all the doctors or all the experts can treat DRTB. No, there are very few handful of experts who are really skilled in treating DRTB as per the guidelines. It is very important. Fourth, if any doctors are treating you only on basis of X-rays or CT scans, you are on a wrong track. You need to have a good microbiological diagnosis and a DST pattern in front of you. You need to ask your doctors, kindly tell me which drugs are susceptible in my strain. In my case, which are the drugs which are susceptible? Which are the drugs which are going to act in my system? That is very important. So you need to have information about the DST pattern. You need to ask your doctors about the DST pattern, so that you are rest assured that yes, you are being treated as per the microbiological diagnosis and not only on clinical judgment. That is very important. Do not stop medicines or the drugs on your own. These DRTB medication second line drugs are really, each and every drug do have their own side effects. That doesn't mean that you just start drugs, stop drugs as per your wish and will. You need to follow the regimen given by your experts thoroughly. If you have any problem or the side effects with a particular drug, please bring it to your notice at the earliest of your experts. That is very important, so that they decide what to be done and how to be done, so that they take care of the side effects developed by those drugs and medicines. So you cannot just start any drugs, stop any drugs on your wish and will. Let experts decide about the reduction of the dose or change of the drugs as per the requirement. Kindly follow cough etiquettes. Do not spit right, left and center. This is a message not only for DRTB patients but for all the patients in general, or rather any public in general. You need to cover your cough and sneeze while coughing. But if I am a DRTB patient or sputum positive patient, chances of developing it to giving my relatives or my near and dear ones are very high. So if you know that you are a sputum positive case, you need to cover your nose and mouth thoroughly so that it don't spread to your relatives, because TB spreads only by aerosol, contacts aerosolically by my nose and by cough. So you need to cover your cough and sneeze. It is very important.